On the last podcast, I talked about shortcuts. You know why nurses make shortcuts? Because they're trying to survive and they recognize the waste that lives in the activities they do. So, you know what they do? They cut out one of those wasteful steps. And that's why I said that it's very rare that the first level shortcut will hurt a patient or create a problem because they're actually cutting out waste. But then what happens when they realize the time that saves them? They will cut out another step and then another step. And at some point in time, they cut out a step that leads to some sort of negative consequence. If all those wasteful steps were out of our procedures, those 3 to 5 unnecessary steps that just exist for the sake of existing, then it would be easier to have our conversations with our staff about not having shortcuts.
Hello, and welcome to this podcast titled Saving Healthcare, where we talk about the issues currently plaguing the healthcare industry and different ways to fix them. My name is Nicole Travis, and I'm here with Darlene Bainbridge. Darlene has nearly 50 years of experience in the areas of a frontline caregiver, a quality director, a risk consultant, a CEO, and a board chair. So today we're going to talk a little bit about the difference between a bureaucratic and a generative quality culture. So, Darlene, I hear you talk a lot about how healthcare is stalled in the bureaucratic quality culture. Can you talk a little bit about what that means and what it means to move to the generative quality culture and the difference between the two?
It's a really important concept for healthcare these days because it impacts a lot of how resources get utilized, how money gets spent, and what the outcomes are of all the efforts that we put into patient care. And the bureaucratic quality culture is an extremely dangerous culture for healthcare to be in right now because of the impact it has on resources, our relationship with the American people, and different things that have the potential to continue to cause healthcare to spiral in this doom loop it's caught up in. So to understand what the bureaucratic and the generative quality cultures look like for healthcare, I think it's important for us to understand how healthcare has evolved through the 5 different safety cultures that Robert Westrom and Philip Hudson described in their work back in the 1990s. Robert Westrom originally identified 3 safety cultures that organizations like we see in healthcare have to migrate through to get to the kind of culture where it all just works for them. They're in control of what can hurt themselves and their patients. At the same time, they're managing their bottom lines so that they can continue to grow and evolve the services that they offer. And then Philip Hudson came along and he built on Robert Westrom's work and he added 2 additional cultures. So it was easier for us to understand what that transition looked like. So the 5 cultures are the pathological culture or the resistant culture that we were experiencing in the 80s when I became a quality director. And then you migrate on to the reactive culture, then to the bureaucratic culture, and then to what they described as the proactive culture, and then the generative culture. So, what those cultural transitions look like. So, when I first became a quality director, we were deeply embedded in the resistant culture. That is where we pushed back any way we could on what was coming out of outside forces as they were pressing on us to develop stronger safety practices. And that's where the game of tit for tat came from for healthcare. Somebody would come up with something that we had to satisfy, and we would figure out how to minimally satisfy it without really worrying if it produced a meaningful outcome. And then in the late 80s, we migrated into the reactive culture that they described. And so the reactive culture is probably best demonstrated by the survey chains that were popular back then. So anytime a regulator or a surveyor was in my building, I had 5 other quality directors that I was responsible for calling and telling them exactly what the surveyors or the regulators were looking for. And then they each had quality directors that they were responsible for calling. And so within a matter of a few days, the whole western part of our state could know exactly what the surveyors and the regulators would be looking for the next time they wandered into a building. And then everybody just kind of ran around like little chickens with their heads cut off, implementing all those things, never asking what it was going to cost, what impact it would have on the workforce, whether it would produce meaningful safety related outcomes. And so that was the reactive culture. And it played out for several years. And then migration from the reactive culture to the bureaucratic culture was just a natural one for us. Everything, the game of tit for tat just became more resource intensive, more antagonistic, involved more players, and this is why the bureaucratic quality culture is so dangerous for us because we've been stalled there since the beginning of the new century. And so we are spending oodles and oodles of money and tying up oodles and oodles of manpower to frequently produce results that are nothing bigger than minimal compliance with the latest round of demands that come from someplace. They come from the surveyors, from the regulators. Now they're coming from the payers, and they're coming from this entire cabal of players. They just keep evolving who say, well, we got an answer for fixing healthcare because we're unwilling to fix ourselves. And then the proactive culture, which is the culture that we so desperately need to move into right now, is the culture where we recognize the danger that lives in the bureaucratic culture and we start managing quality and risk management on our own and with a goal of doing it in more business smart, resource wise, workforce supportive, defect free, and patient focused ways. And it's an extremely important culture for us to get in and start working in because Westrom and Hudson say that it's the longest of the cultures because there's so much change that has to be embraced. And for us, that's huge because we've been doing this for so long, the way we've been doing it, that it's going to be really easy for us to take 2 steps forwards, 10 steps backwards, and just keep losing in an environment where is now not the money or the manpower for those kinds of losses. And then from the proactive culture, you migrate into the generative culture. It's a truly business oriented quality culture where the goal is to manage as much as you can to the one in the 110-100 rule as efficiently, and as effectively as humanly possible. So the money works better. The manpower works better. We get rid of all the waste and the crap that lives in healthcare right now that makes it really hard to meet the needs of our patients. And so the generative culture has to be our goal in healthcare. It's a generative quality culture that operates with generative safety goals to get it right the first time and do it in ways that work for everybody. It works for the patients, it works for us, it requires less rules and regulations, it works better for the surveyors. Everybody wins if we ourselves can get to a generative culture.
So you mentioned the doom loop. Tell us a little bit about the doom loop.
So the doom loop is a self-perpetuating story of decline, like the one that's been playing out in healthcare since the 1970s. So it's where a business makes a decision that is remains continues to be hurtful to itself. It generally accentuates the damage done by a previous decision. And because if the industry remains an entrenched player in old school practices, it sets the stage for another destructive decision to be made that just keeps feeding the financial, operational, and reputational doom loop of the industry. Probably one of the best examples for healthcare is the way we've managed surveys over the last 50 years. Our survey model has been one where we need to know what the surveyors are looking for so we can do just enough to make them happy when they come into our buildings, but not enough to be in control of what will generate the next round of survey standards that's going to emerge out of an environment where people want safety. They want reduced costs. They want better patient experiences. And so we just keep circling the drain here in this doom loop where we pass our survey, and then we really don't care if we hang on to all the hard work we put into getting ready for that survey. And so then the next time the surveyors are going to come, the work is harder, the lists are longer, and we just keep feeding the financial, operational, and reputational losses in our buildings because patients aren't happier. The workforce isn't happier. I had one CEO call me one day and he said, I was told to call you because we're trying to get ready for survey. And he said, I just had a meeting with all my managers telling them how, we got to get ready for the surveyors to come. Everybody needs to hunker down and make sure everything's in place that they're going to be looking for. And he said, my managers basically looked at me and said, you can figure it out on your own. And they all got up and walked out of the room except this one woman. And he said, she sat there and she looked at me and she said, I think you need to call Darlene Bainbridge because we can't do this anymore. We cannot continue to take time and resources away from patient care to keep climbing the same hill over and over and over again so we can pass the next survey. But it's a doom loop for healthcare because every time the surveyors come back, the list is longer because we didn't get control of the list the last time they were in the building. There's still stories of patient harm, and there's still issues that are coming out of our environment. And so what's the answer? Some outsider writes some new requirement for us to satisfy so that we can demonstrate we can at least temporarily be in control of those things. And even our staff has had their fill. They're just looking at us and they're saying, sorry, we're going to take care of our patients to the best of our ability, and you can figure out in the C-suite how to pass the survey on your own. And so we've got to get control of this. It's like, I remember probably my very first exposure to this whole dynamic was when I was a nursing student. And my co-students and I were going to this inpatient mental health facility for 8-week rotation. And we all just hated to go there, not because of the patients, but because of the conditions those patients lived in. The furniture was tattered and torn. The curtains kind of hung on the windows. The place reeked of urine and feces. And it was just a terrible environment. And then one day we all walked in and there was all this new furniture, new curtains on the windows. The sleeping areas for the patients looked wonderful and it didn't smell. The odors were gone. And I remember us talking on our way back to the school about how somebody must have finally decided they cared about those people and they cleaned that place up. And then the next week we came back and all the new stuff was gone and all the old stuff was back. The tattered furniture, the disgusting carpets, the curtains that kind of hung on the windows. And I'll never forget, we looked at the nurse who was working that day and we said to her, what happened? Where's everything? And she just rolled her eyes up in her head, suggesting how stupid we all were. And she says, well, the surveyors have come and gone. So all that new stuff has been moved to the next location where we anticipate the surveyors to arrive. And this 50 years of this kind of behavior is what has brought healthcare to where it is today and has positioned the industry for a lot of our providers to die if they do not get control of the costs and losses that they are now accruing because of the way they practice quality. I'm sure that the leadership of that mental health facility thought they were winning the game. Because for years we've thought we were winning the game when we would do just enough to make the surveyors happy while they were in the building, and then we would just go back to the old ways. We got our accreditation, we got whatever pieces of paper we needed in order to continue to get paid by the Medicare program and the payers. So we had won. But what we were doing was slowly and insidiously losing a little more power, a little more influence, little more earning potential, and a little more public goodwill every day because we were not in control of the environment where we delivered patient care.
Do you think that some of these issues come from the mentality that healthcare is not necessarily a business and it's just something that will always be here and that there will always be federal funding that comes out that helps them to keep alive and that they don't need to run as a well-oiled machine and keep trying to improve, truly improve the way that they operate and that they run to keep the patients wanting to come back to them and not looking at them as, well, this is the closest hospital. I have to go there.
I think there's a lot of things that contributed to bringing healthcare to where it is today. I mean, and we need to understand all of them. I mean, if we want to go back to the very beginning, this started with the scientific revolution for the industry that started to play out back in the 1940s. And physicians were struggling with the difference that made in how they delivered patient care. Because all of a sudden, instead of just being able to practice the art of medicine, where you could have 5 doctors treating diabetic patients and all treat them differently, but that would be just fine because it was like Picasso putting his autograph on his paintings. All of a sudden, we had science that was saying, this drug might work better. This treatment plan might work better. And so we were already struggling with some of this stuff when we moved into the technological revolution. The technological revolution just speeded it up and it made the environment a much riskier environment. All of a sudden, we could deliver care to a patient that we'd never been able to deliver before and hurt them. And we didn't understand it wasn't about us. It was about the technology and how we managed the technology. The risk came with the technology. And if we had been willing back then to manage the risk, embrace the changes that would allowed us to better manage those risks so the patient outcomes would be better, this environment would be totally different for healthcare. But see, we weren't. We were already struggling with the dynamics of the scientific revolution. We all of a sudden had all this new technology where we could make big money and we could render all this care, and we could not see outside the narrow box of where we were. And we've struggled to escape that box ever since. And because of what we were able to do to save patients' lives and treat diseases we'd never been able to treat before, we developed this attitude that, well, who else is going to do it? Just we have to survive because we're healthcare. And the problem is there's a lot of industries over the centuries that and guilt-like groups like physicians who have believed that and have kind of taken the same road healthcare's taken, and a lot of them have ceased to exist. Because like I said in one of the previous podcasts, healthcare has to exist. I don't know if healthcare in its current form has to exist. If somebody could come up with a better answer, an answer to patient care that delivered better outcomes, controlled for the risks that cause patient harm and just got control of everything right now that's working against healthcare, which wouldn't be impossible to do, then the question is, why do we need entrenched healthcare providers to continue to be in the equation? Those that want to sit around and pretend that medical errors are just stuff that happens to unlucky patients, providers who are more concerned about the money they're chasing than they are the balance they need in order to manage both sides of the coin. I think a really great example of that was something that just has played out in the last decade or so. And that's where all of a sudden we saw corporate America saying that they would be willing to fly their employees across the country for patient care if they could get better care. They were willing to do that. And so a lot of our bigger healthcare systems latched on to that because they saw the money it represented. If you've got Lowe's or Home Depot or Amazon willing to fly their employees into your healthcare center from all over the country, think about the money you could make. But what they were looking for was that provider who was going to help them reduce costs, minimize the potential of medical errors that impacted whether how long their employees stayed off and whether they came back to work at all. That's what they were looking for. But we didn't have a single healthcare system in this country who recognized that and who was willing to give up the short-term dollar to make the long-term dollar by giving those companies what they were looking for. And so how long did that last? Not very long, because it didn't take very long for corporate America to figure out that they weren't going to save anything because their definition of safety and quality, what they were looking for, didn't match what we were delivering. It's like there's a story that I frequently tell these days because it's pretty new. And it happened to the husband of a colleague of mine. He wasn't feeling well, and he just wrote it off to be in the flu or something. So he let it ride for a while and then didn't get any better. So he went to this urgent care center to see what was going on. And well, the provider he saw couldn't tell him what was going on, why he was sick, why he actually had symptoms of an infection. He gave him an antibiotic to take. And when he didn't get any better, he went back to that same urgent care center and he saw another provider. Because consistency in providers these days is something that's really hard to achieve for a patient. So he saw another provider. And that provider said, well, I don't know what's wrong with you either, but I'm going to give you a different antibiotic. And this one should work better because it's more broad spectrum in the bacterias it will kill. And so he didn't get any better. So we went back to that urgent care center for a third time and saw another provider. And that provider, still not knowing what was wrong with him, doubled down on the antibiotics and gave him 2 antibiotics in order to treat his infection. And he's declining all the time. So finally, he ended up so sick with a Clostridium difficile infection of the bowel because of all the antibiotics he had had that he ended up in the hospital, very ill. And it was while he was in the hospital, they figured out that his issue was 2 abscessed teeth. He had 2 abscessed teeth. They pulled the teeth, treated the infection, and his issue went away. All right? But it has taken that man over a year to recover from that. Higher healthcare costs, more frequent physician visits, and it's taken him over a year to recover from that. And this is what the doom loop in healthcare looks like on an individualized basis. Right now, it is estimated that roughly 3 million people experience infections from multi-resistant organisms. And a lot of those multi-resistant organisms are the product of that kind of care. And they estimate that it's costing us about $4.6 billion to treat all those infections. Now, the new numbers are that by the year 2050, at our current pace, we will have 8 million people suffering those kinds of infections from multi-resistant organisms, and the cost to the country will be about $55 billion. And you know where a lot of that money's going to come from? It's going to come out of the operating margins of our hospitals and our physicians, because people are tired of paying for this kind of stuff. They're tired of watching their premiums go up. They're tired of paying out of pocket. And so the nature of the doom loop and the nature of the game of tit for tat is we will just keep writing rules, regulations, and payer restrictions that make more and more of that money come out of our hospitals. Because the fact of the matter is, our hospitals and our physicians are the only ones who can fix that. We are right now in a stage of the game of tit for tat where the average hospital can effectively satisfy all the regulatory and survey requirements for antibiotic stewardship and not make any real difference at all in controlling for the growth of multi-resistant organisms, because it's a process-oriented game. You know, do you have a champion for your antibiotic stewardship program? Do you have a committee? Do you have this? Do you have that? And you can put all those things in place and make no difference at all.
So I feel like you see this a lot in healthcare in a lot of different areas. We're seeing a ton of different projects come out that states and the federal government are requiring hospitals to participate in, where they have to collect this data, they have to show that they're meeting these requirements, but it's not actually benefiting in the larger scheme of things. And I think HCAPS is a primary example of this. And we just, from one of our other hospitals, the hospitals are required to participate in this, or they're required to meet all these standards with this survey. But are we actually seeing improvement? Is it really benefiting the patients to the extent that it's worth spending the time doing that specific survey instead of customizing and creating the materials that will benefit that facility specifically?
I'm not sure the answer to that question, but I think it's a really important question that needs to be answered, because we've got to know now that everything we do is making a difference. That it's kind of like I asked one CEO one day, I said, "So what does it mean for you to be in the 95th percentile on a patient satisfaction question where the herd is running around 78% and the question's not even important to the patients?" But we see a lot of that in healthcare right now because it's the nature of the game. It's how the game of tit for tat has evolved, and we're all trapped in it. We've gotta now step back. I mean, I am of that magical age now where I get to participate in these kinds of surveys. And so one day this woman calls me. She asks me if I had time to participate in this survey with her. And I said, "Sure, I'll do it." A lot of times I don't, but I did because I had time that day, and I wanted to see if the process had improved at all. And so we spent about 20 minutes on the phone, her asking me all these questions. And on 2 of them, I scored the hospital experience pretty low. So we get to the end of the survey, and she's thanking me for participating and taking the time to do it. And I said to her, "So don't you want to know why I scored my experience so poorly on those 2 questions, so the hospital have an idea what to work on?" And she said, "Nope." She says, "That's not part of the survey process." And see, because the survey is the outcome. Getting the survey done is the outcome. The outcome is not to figure out what we have to do differently to make our patients happier. And because those surveys are dictated to us from outside forces where we have very limited power to change them so they could be more meaningful, and there's no teamwork effort that goes into this process, the return rates on these surveys are horrendous. We're always getting calls from our hospitals and saying, "Is there another vendor who could give us better return rates?" No, there's not. People are tired of answering the same questions over and over and over again, and then not seeing any results from taking the time to answer them. A really good example of that is one of our hospitals that I worked with one time. They scored really poor on the HCAHPS question about the quietness of the patient environment. And no matter what they did, they couldn't improve that score. It was always terrible. And so they spent oodles of money and did a lot of damage to their relationship with their workforce with all these corrective action plans because the one thing they weren't going to do was ask the patients why they weren't happy. So they did things like this. They mandated that the nurses buy special shoes, quieter shoes. They mandated that they buy equipment with quieter wheels. They disciplined nurses who they decided talked too loudly. They made nurses carry phones around in their pockets, so when they were down the halls taking care of patients, the phone ringing at the main desk wasn't gonna upset the patients. So how upset do you think the patients were when the nurse is standing there trying to deliver care to them, and the phone in her pocket's ringing or his pocket's ringing? They did all these things. It just drove me crazy watching them. And I kept saying to them, "Why don't we just ask the patients why? Why they score you so poorly on that question?" And they'd say, "Oh, we can't because we might get in trouble." And so finally, the board was so upset, the CEO agreed to ask the patients why they were scoring that question so poorly. And you know what the answer was? It was a set of fire doors. There was a set of fire doors on their patient care units that the doctors and the lab techs and all the caregivers used all day and all night long to more easily access the patient care floors. Those fire doors came in off the physician parking lot. So when a physician got called in at night for a patient that was in trouble, they got out of their car, ran up, it came in that back door, ran up those stairs, and let that door slam as they came through it. It slammed all day and it slammed all night. And so we came up with a plan where people would access those patient care units through a separate set of stairs at the other end of the hallway, away from the patient rooms. And guess what? Their scores magically improved. But see, this is the kind of stuff that now has to happen in healthcare. People need to sit down and they need to say, why? Why do we have medical errors? Why are our patients unhappy with us? Why can't they score us good on a certain question? And then we need to address those things with business smart answers. Answers that actually make a difference. Because one of the things I learned when I was going through my cancer care was I was so upset with my cancer treatment center by the time I got done with that experience. Because, like I've mentioned in previous podcasts, I had 5 medical errors that could have killed me or negatively impacted my patient outcomes. Sepsis from a central line insertion, 2 significantly miscalculated chemotherapy doses, a near miss with an air embolism into my central line, and 5 high-dose radiation treatments that I was not supposed to get. And even the radiation oncologists thanked me for catching them, so it didn't do unnecessary damage to my heart and lungs. And every single time I met with the leadership in about a dozen meetings to discuss those errors and the simple and small things that hospital could have done to prevent the same kind of error from happening to another patient. The answer I always got was how well they had just done on their most recent survey without the issues I raised being issues the surveyors had raised. How there wasn't a rule or a regulation that mandated them to address the things that happened to me. And so there was just nothing they could do about them. And the one thing I learned from the patient side of this whole equation was I couldn't care less by the time I got done going through that care if that hospital died under the weight of the rules, regulations, and reporting requirements that it might take to improve the safety of future patients because that hospital was not willing to do it on its own. It is very easy for us to change some of our practices, to build stronger practices without spending a lot of money that would protect our patients, would keep them safer, would make their experiences better. But we have to be willing to do it as providers. Because as long as we're going to sit around and wait for somebody else to do it for us, it is more than likely not going to happen. And with enough time and enough entrenched choices, even some of our biggest hospitals are at risk of ceasing to exist. Because as we run out of money and we run out of manpower in healthcare for surviving, for offering more care, new care to our patients. I mean, why buy a piece of equipment if you can't staff for it to use it? This is now a situation where, as an industry, we have to recognize the damage that the bureaucratic quality culture does to us, and we need to start making the moves to get to that generative culture where we will survive, where we can rebuild our financial, operational, and reputational health because we do things in much more business smart ways, much more patient-focused ways, in ways that protect our workforce from all the busy work that lives in the bureaucratic quality culture. It's like the average procedure in a hospital right now contains 3 to 5 unnecessary steps. There's steps that have been added over the years because to please the surveyors, to create some corrective action plan to a survey deficiency so we can say we fixed it without really fixing it in a business smart way. 3 to 5 unnecessary steps. So every one of those steps on average consumes 3 minutes of staff time, and every one of those procedures, 200 of those procedures get carried out 500 times, which is easy, and especially in our larger healthcare organizations, we are talking about roughly 9 FTEs of staff time. But we don't think anything about that because what we don't understand is in a bureaucratic quality culture where the measure of success is compliance, nobody cares that those wasteful steps are wasteful. If they exist, they have to be carried out, or it's a deficiency, where you get to spend even more money on activities on corrective action plans, where you'll probably create another wasteful step for your staff to have to carry out. And what are you fixing? I remember one time one of our directors of nursing I was working with called me. She was in a panic. an absolute panic because her nurses were mutinying on her. And I said, "Well, why would your nurses mutiny?" She says, "The surveyors were here and we got cited because we weren't getting nursing assessments done in time because we have rules and regulations for everything. Getting the patient assessment done in a very timely manner is important to figuring out safe and effective patient care, and they weren't doing that." Now, at the time, their nursing assessment was 6 pages long. And so the corrective action plan that they submitted for that deficiency allowed for a nursing assessment that was now 10 pages long. They had gone from a 6-page assessment to a 10-page assessment to create a corrective action plan for a deficiency where they weren't getting nursing assessments done on time. And when she released that new form to the nurses, it was just bedlam in that building. Her nurses turned on her. She ended up losing her job over it. And it's because nobody thinks in healthcare about these kinds of things. Nobody steps back and says, "Where's all the waste in our buildings? Where's the way things that we could do where we would work smarter and keep our patients and our workforce safer?" Because we are so embedded in the bureaucratic quality culture where the game of tit for tat thrives, it just plays on. More rules, more regulations, more this, more that. And what's getting better in the eyes of the American people? Absolutely nothing. And so it's really important, Cole, that our hospitals, because our hospitals have to be the ones to start this ball rolling. We need to do this for every type of provider in the country. But our hospitals are the biggest of our providers. They are the riskiest of our providers, and they have to start the ball rolling. They have to, because then just like the way we got into this mess, where it started with the hospitals and then it just sucked every other kind of provider into it, like nursing homes, surgical centers, and all these different types of providers. Our hospitals have to be the ones to now start the ball rolling for fixing it, and then use what they learn and what we can gain from that to help every other type of provider in this country position themselves to survive. We're losing nursing homes and we're losing home care agencies and we're losing all kinds of providers at an alarming rate. And nobody's even really talking about it because they're kind of out there, you know? But you know who does talk about it? The hospitals. Because when they get ready to send somebody home, do you know how hard it is to find a home care agency right now to take a patient? Or to find a nursing home where you can transfer that patient to, or all the different types of providers. And so the death rate is actually of healthcare providers in this country is actually bigger than we think it is because we don't talk about all the ancillary providers that are dying and now complicating the patient care environment, complicating our ability to give people the kind of care that they're looking for, that they need. So, you know what happens? We send them home. They're not really ready to go home because now shorter length of stays is important for several reasons. We send them home. They're not really ready to go home, but we can't send them. There's no place else to send them. So they go home, they deteriorate, and then guess where they end up? Back in the hospital. Frequently in worse shape than they left. So we start all over again, spending money to take care of patients and it's just this vicious cycle. And what's anybody doing to try to fix it? Not a lot. Because everybody's now lost in their own piece of the game. The payers are lost, the regulators are lost, the surveyors are lost, and then we got all these players who want to enter the game saying, "Oh, we'll fix it. We'll fix healthcare." And you know what they typically do? Is they complicate it because they add another layer of bureaucracy to it and busy work to it, and it's just and the doom loop plays on.
So what do we do? How do we start the ball rolling to fix this, but still comply and not end up getting ourselves in more trouble because you have the surveyors over here looking to make sure you are complying with everything, but then you have the hospitals over here that really need to take 10 steps back and get control of all of this stuff in a better way. So how do we start getting that ball rolling?
We have to start practicing a kind of quality and risk management that's hard to argue with. I mean, I've spent the last at least 30 years of my life having lots of conversations with regulators and surveyors on behalf of hospitals I work with so that I can help the hospitals I work with break free of this stuff. All right. But I can do that, one, because I'm willing to do it, and two, because I understand quality and risk management well enough to have those conversations. And when you understand it well enough and you practice it in a strong enough way that it's tough to argue with it, then it's easy to move this ball forward and then to start co opting these other players in. They're just as terrified about surviving as we are. But at some point in time, everybody's got to sit down at the table and start having a serious conversation about how we collectively fix this. It's like one time, one of the CEOs we work with called me and he said, "I have some people sitting here that you need to talk to." And I said, "Okay." I said, "Who are they?" And he said, "They're the surveyors." He said, "They want us to take everything out of SQSS that has been in compliance for over a year because it's not a problem anymore." And I said, "Okay." I said, "I'll have that conversation." And so I get on the phone with these people and I said, "I don't understand why you would encourage the hospital to take their regulatory responsibilities and their patient safety responsibilities out of SQSS because the system helps them maintain them every single day. Doesn't matter who's working today because the system knows what has to be done today." I said, "Why would you want them to take it out?" And this one woman says to me, "Well, because they've been in compliance for over a year, it's not broken anymore." And I said, "Well, then maybe we should call all the airlines and tell them they can stop checking the planes because we haven't had a major plane go down and kill everybody on board in a long time. Why are we still checking the planes?" And there was this dead silence on the other end of the phone. And finally, one of them said, "I get it." I said, "They use SQSS in their hospital to achieve the same thing the airline industry achieves every day, to have no plane fall from the sky, crash and burn, and kill everybody. They use SQSS to maintain their control of the patient care environment. So every day, we know everything that needs to be checked is getting checked, and that we're not giving outdated meds to our patients." I said, "If they take all that stuff out, how are they gonna control for that? Especially in an environment where we can't even count on retaining a nurse for a year." And the woman came back and she said, "We get it." And she said, "We're good with this." But see, those are the kinds of conversations that now have to be had in healthcare. And our leaders and our organizations need to understand this stuff well enough that they can have those kinds of conversations. Not because they're going to whine that this isn't fair, that we got another regulation to comply with, but because we have a better answer. we have a better answer to patient safety than what's come out of the game of tit for tat for the last 50 years. A better answer than what comes out of the bureaucratic quality culture that we're dying under. Like I've said in both of the previous podcasts, this is something that has to start at the leadership level. You can't just look at the quality director and say, well, go out there and make everybody do it. Well, you're not championing it. You're not practicing. She's out there preaching or he's out there preaching. This has to start at the leadership level. So we step back and we just start cleaning it up. We start getting control of things, maintaining control, cleaning all the waste out of our activities. On the last podcast, I talked about shortcuts. You know why nurses make shortcuts? Because they're trying to survive. And they recognize the waste that lives in the activities they do. So, you know what they do? They cut out one of those wasteful steps. And that's why I said that it's very rare that the first level shortcut will hurt a patient or create a problem because they're actually cutting out waste. But then what happens when they realize the time that saves them? They will cut out another step and then another step. And at some point in time, they cut out a step that leads to harm, that leads to some sort of negative consequence. If all those wasteful steps were out of our procedures, those 3 to 5 unnecessary steps that just exist for the sake of existing, then it would be easier to have our conversations with our staff about not having shortcuts. And so it's extremely important now that from a leadership level, you just step back and then ask yourself if the answer you come up with is a smart one. I mean, you don't go from a 6-page nursing assessment to a 10-page nursing assessment to address a deficiency about timeliness. But in healthcare, we do that all the time.
Yeah.
We've always done it all the time because the goal is to throw an answer out there that makes somebody happy or creates the perception we're doing something. So we over here can keep chasing more the way Jim Collins describes it. But you know what the problem is? We can't keep chasing more now because there's not the kind of money in chasing more that there once was. So it's extremely important now that we chase new technologies. We chase what will advance patient care, but we do it in a highly balanced way that controls for all the costs, losses, and risks that undermine what we can do for the American people.
Yeah. And one of the things that I keep thinking about as you're talking about moving away from this bureaucratic quality culture is the turnover, and how if you are supporting the staff and helping them to understand this and move to that more generative culture, it could help with the turnover, because turnover is a huge problem right now, right? The tenure of a quality director is abysmal. I mean, the turnover in quality positions is consistent, and you cannot have a quality program that is strong and consistent when you're losing quality director after quality director after quality director and bringing new people in constantly and restarting that process.
I agree. I mean, the tenure right now on just about anything, anybody in an administrative position is pretty sad. I mean, even CEOs, there is no reason to decorate your office if you're a CEO these days, because the question is how long you're going to last, especially if you bring old school business philosophies with you, because all we keep doing is returning the same old stuff and then sitting there and being unable to explain to the board of trustees why we're deeper in the doom loop today than we were 1 year ago.
I mean,
We
it's like
can't explain that.
It's like the
Yeah,
Boussy despair. It's you bring a new person in, they bring their new systems, they bring their new processes. Everybody has to learn it. That person leaves, they bring a new person in. Here comes new systems, here comes new processes. We have to relearn that. And it's
right.
just a consistent, perpetual cycle of not knowing what we're going to do next year or next week or next month
That's
because it's
right.
not going to change.
That's right. That's right. Because all we do is throw answers at things. It's
Mhm.
like throwing spaghetti against the wall and seeing how many strands of it will stick.
Yeah.
We now need to stop doing that
Mhm.
because we don't even recognize when we destroy our relationship with the workforce. We don't even recognize that when we look at somebody and we say to them, well, if you'll just fill out this one more form, life will get better. You know, we've been telling our staff that for over 30 years. One more form, one more something, and life will get better. Well, the fact of the matter is, the healthcare workforce has figured it out. Life isn't getting any better. It's not going to get any better. And they might as well just go find a job someplace else until healthcare leaders figure this stuff out
Yeah.
because they're tired. I talk to nurses all the time. And you know what? They're tired. They're tired of having to choose between filling out a form that they know serves no purpose and is redundant of 3 other forms that they have to fill out and taking that time away from their patients.
Yeah.
And you know who creates those forms? People hired up in the organization than they because it's an easy answer. I'll just create this new form. And we'll make all the staff fill it out, and we don't care if it's a duplicate of another form. And when we were building EHRs, we should have gotten rid of all the duplication. It's like we've learned in SQSS. You put a piece of information over here, and then you let it automatically flow over here so nobody has to put it back in again. We didn't do that with our EHRs. The redundancy in EHRs is mind-boggling. And it takes time away from patients. It's like the other day, I took my mom to the doctors again. I've already told you one story about taking her to the doctors. I took her to the doctors again because I cannot let my parents go to the doctors by themselves. All right. So the last time, the doctor had ordered a prescription for my mother. And when I got home, before we filled it, we looked it up, and of course, it was the base of that medication was a drug that my mother cannot take because she's severely allergic to it. I mean, to the point where she almost died one time from an anaphylactic reaction from that derivative. And I know it's in her chart. And so I said, You're not taking that. And so we came up with an alternate answer. So we go back to see the doctor that ordered it. And I said, Well, she didn't take it. And I told her why. And she said, Well, you're right. If she has that allergy, I shouldn't have ordered that. How did I order that? And she was visibly upset. I said, I just want you to know she did not take it. And we came up with an alternate plan. So we're talking, and the doctor she kept fidgeting, and she looks at me and she says, We got to stop for a second. I got to figure out how I missed that. And I said, Okay. And so she's going through the electronic health record. It took her the better part of 10 minutes to find the documentation that said my mother was allergic to that drug.
But why isn't there a trigger
And she
that would have
looked,
thrown up and said, "She can't take this," when they
I
ordered
agree.
the met? That's the question, right?
I agree. She says, I found it. It's here on this page.
Mm.
And I said, That's why you ordered it. Because it just took you the better part of 10 minutes to find that piece of information. So you would not have ordered that for her.
Yeah.
But see, we need systemization in healthcare. And I'd like to dedicate a whole podcast to what that means. But we need good systemization. We don't need to just throw another computer system at healthcare and not care if it takes us to a better place. And so it requires us now to step back and say, so what better place do we want to be at? What does that look like? And then we need to start making it happen with us driving the bus, not with somebody else driving the bus, but with us driving the bus. We're more than capable of doing that. We understand patient care. We understand the intricacies of patient care. But we now have to be the ones that step back and say, I don't care how we did it 10 years or 20 years or 30 years ago. Today, we are going to do it in a way that makes outcomes better, makes life for our patients better, makes life for our employees better, and that positions our hospitals to survive. So then we can help the rest of the industry survive. Because for a lot of our healthcare systems, they've run around and they've bought up all these different types of healthcare providers. What does a hospital CEO really know about running a nursing home? I mean, I used to run a nursing home. I have a nursing home administrator's license that I've now put in hiatus, but it's a very different world. You cannot just take what you do in a hospital and drop it into a nursing home and say, life's good. But we have to build the systems to make it possible to run different types of patient care settings with the same level of efficiency, effectiveness, and control that we run a hospital with, but understanding the variables that have to be different.
S- So, just in an effort to wrap up today's podcast, before our next podcast, what would you recommend that our listeners think about?
So, first of all, I would like them to start, like I've said on the last two podcasts, I want them to start, take off the rose colored glasses that the industry's been wearing for 50 years and start looking at where they can clean up their patient care environments, get rid of waste, figure out how to make it work better and start making that happen. The other thing, if you wanna understand, like, the difference between a bureaucratic and a generative culture, you could go out to our website. I've written a whole piece on what are the characteristics of a bureaucratic culture, what are the characteristics of a generative culture, and then how you get from one to the other. And so I would strongly encourage people to go out there and read that piece. There's other pieces out there. There's one on what it means, what the game of tit for tat looks like, and how we break free of it. So, but this is now about us. We don't need to build anything new. All the answers we need are out there. You take the work from Jim Collins about the 5 stages of decline that we're stuck in. You take the work of Hudson and Westrom and the evolution through 5 safety cultures looks like. There's all the information we need to fix healthcare is out there. We don't need to invent anything new or create one more thing for our staff to do. But what we have to do is we have to read all that literature with out the rose-colored glasses that for 50 years have said, "This doesn't apply to us. We're healthcare. We're special. We don't have to understand this kind of stuff." I would suggest that anybody who's interested get Jim Collins' book titled How the Mighty Fall and Why Some Companies Never Give In and read it with the perspective of how it applies to healthcare, because it is exactly what's happening to healthcare. And if we don't hurry up and figure out the difference between continuing on the path we're on and what he describes as renewal and recovery, I'm not sure what the rest of this decade is going to look like for healthcare, but I am pretty confident it's not going to be pretty.
Okay. Well, thank you for that. And thank you, everybody, for participating and listening to our conversation today. I hope you found it helpful. If you are interested in learning more information and looking at the documents that Darlene discussed, please visit our website at qualitycalendar.com. Again, that's qualitycalendar.com. And if you'd like to learn more or be notified about our future podcasts, please make sure to like Saving Healthcare on your podcast viewing platform of choice. And we hope to see you on the next one. Thank you and have a great day. Bye-bye.